Hello, this is Nakagawa speaking. And good afternoon, every persons. And I'd like to welcome you all and thank everyone for joining this meeting. And as you know, this meeting, APSC JCS 2020 webinar, is held as a web-based online meeting due to the COVID-19 pandemic. And the topic in this session is coronary artery disease. And my co-chair is Ashok Seth from India. Please, some self-introduction, Dr. Seth. Hello. Please, mic on.
Thank you very much, Professor Nakagawa. I think it's a privilege to be amongst you all for the 84th annual scientific session of the Japanese Cardiovascular Society, Circulation Society. My name is Dr. Ashok Seth from New Delhi. I also happen to be the president of the Asia Pacific Society of Interventional Cardiology and the past vice president of the Asia Pacific Society of Cardiology. I'm an interventional cardiologist, but I just want to bring to your notice that we have very important topic on coronary artery disease. And whatever the specialization in cardiovascular sciences, every cardiologist, even a cardiac surgeon, needs to understand the management of coronary artery disease, because the advancements in management of coronary artery disease have actually been immense over the last 10 years. Now, on the platform, as you see today, are very important topics. And we understand that these important topics seem to be haphazard because on one stage, we are developing the ischemia study for medical therapy versus PCI, and then there's a discussion on DOACs and then short DAPT. But I want to take you back to understanding that these are very well-knit program today, and it's going to benefit us all. It is very important to understand the background as well as the results of the ischemia trial, because that puts into the evidence-based practice of coronary artery disease. And we want the best for our patients all the time. We don't want to overuse invasive and interventional techniques, but we don't want to underuse them either. We want to benefit our patients to the maximum. So the decision-making process has to be sound in the 2020, as we say. I also want you to understand that why it's so well knit together. We talk about DOACs. You must remember the fact that it was in 1949 that warfarin was the first drug to be shown to prevent heart attacks in patients with coronary artery disease. And in fact, the subsequent trials with aspirin showed that aspirin, a cheap drug, was also useful in preventing heart attacks or myocardial infarctions in patients with coronary artery disease. And because they were bleeding with warfarin, warfarin went into the background and antiplatelets took over in the 70s and 80s and 90s, and then newer antiplatelets came in. But it's time to start understanding that DOACs may actually have a role in decreasing heart attacks and improving outcomes in patients with coronary artery disease, ACS, and stable patients. And then when we go to the next step and say, we're going to use DOACs, or are we going to use dual antiplatelet, or are we going to use aggressive antiplatelet, which is a cornerstone of medical management of coronary artery disease or management of coronary artery disease per se, then you say, where is the ischemic risk versus the bleeding risk for a particular patient? It's so important. On one hand, we have aggressive antiplatelets and anticoagulants, which can prevent myocardial infarctions and improve long-term outcomes. On the other hand, at the expense of increasing the bleeding risk, and therefore, how much shorter can we give these aggressive antiplatelet, anticoagulant therapy to get the right balances? I think what's very important is going to be that this is going to answer many of our questions. And I also want to state why it's important is because some of the seminal trials on these have actually come from Asia Pacific region over the last 3 years. And they have altered the way we manage our patients. They've influenced the way we manage our patients, but also the important fact that they're globally representative and certainly representative to our Asia Pacific region. So with those trials being presented to you today, all of you would be able to formulate a policy for your patients for optimal management of coronary artery disease. So we look forward to this session from the greats of the Asia Pacific region. Thank you very much.
Thank you. Very nice introduction and it's very important keynote lecture. Thank you.
Thank you.
So, Dr. Seth, please moderate next Dr.
Right.
Tsujita's presentation.
So I think, thank you very much. So we go on to the next talk, which is an important talk by Professor Tsujita from Kumamoto University. He's going to give us an overview of PCI and medical therapy state of the art prior to the ischemia trial and why the ischemia trial was conducted. This is very important as a background before we start understanding ischemia trial. So over to you, Dr. Sensor Tsujita Senso, for this talk.
Thank you very much, Professor Ashok Zach. Very nice to meet you in this session.
Pleasure meeting you.
Very welcome. My topic today is PCI versus medical treatment. I want to summarize the overview before ischemia trial. And this is my SHOI slide. I have no financial conflict of interest to discuss concerning the presentation. As you know, we have two goals when treating a patient with stable coronary artery disease. First, to reduce their risk of death and ischemic events, for example, myocardial infarction. In other words, improving quantity of life. And secondary, to reduce ischemia and relieve anginal symptom. In other words, improving quality of life. So let me review of the evidences before ischemia. In the first era, CABG versus medical therapy, no CABG was compared in 70s to 80s. In the second era, PCI using bare metal stent versus medical therapy, pre-optimal medical therapy was compared in 90s to noughties. And finally, in the third era, PCI using bare metal stent versus optimal medical therapy, OMT, was tested in noughties. Let's move on the first era on the agenda. Professor Yusuf carried out a systemic overview using individual patient data from 7 randomized controlled trials that have compared a strategy of initial CABG surgery with one of initial medical therapy to assess the effect on mortality in patients with stable coronary heart disease. As shown in this slide, the strategy of initial CABG is associated with lower mortality than one of medical management, especially in high to medium risk patients with stable coronary artery disease. In the second era, based on this meta-analysis of 11 randomized controlled trials, in patients with chronic stable coronary artery disease, in the absence of a recent MI, PCI did not offer any benefit in terms of death, MI, or the need of subsequent revascularization compared with conservative medical treatment. In the third era, strategy trials of revascularization like COURAGE and BARI 2D trials had been accomplished in stable CAD patients with established OMT. Before the widespread availability of drug-eluting stents, strategy trials that tested the incremental effects of revascularization added to medical therapy did not show a reduction in the incidence of death or MI. Let's move on each trial. In the COURAGE trial, approximately 2,300 stable CAD patients were randomized to PCI plus OMT group versus OMT alone group. In this trial, both groups received intensive guideline-driven medical therapy and lifestyle modification. As you can see in this right panel, there was no difference in long-term outcome between the groups. However, looking at the result in detail, 33% PCI rate in OMT group and 21% repeated PCI in PCI group were observed. So such inconclusive results have been considered to be mainly based on the bare metal stents utilized in this trial. This slide shows the study design of Bari 2D trial. The investigators randomly assigned 2,368 patients with both type 2 diabetes and heart disease to undergo either prompt revascularization with intensive medical therapy or intensive medical therapy alone. Primary endpoints were the rate of death and a composite of death, MI, or stroke. Randomization was stratified according to choice of PCI or CABG. As a result, 5-year death rate for the group receiving revascularization plus optimal medical therapy was 13.2% versus 13.5% in the group receiving optimal medical therapy alone. The difference between the two treatment groups did not reach statistical significance. So, the investigators concluded that prompt revascularization did not improve survival in diabetic patients with stable coronary artery disease. Even when stratified by the revascularization strategy, PCI and CABG, clinical benefit of PCI addition on the OMT was not observed. Far from it, in terms of principal secondary endpoint, that means death, MI, stroke, beneficial impact of revascularization was seen only in the CABG stratum in diabetic patients. The major contributor of the results might have been the lower rate of drug-eluting stent utilization in the Bari 2D trial. Also, greater attention has been paid regarding the impact of extent of myocardial ischemia on the heart endpoint. So, the hypothesis of FAME2 trial was thus that OMT plus FFR-guided PCI improves outcome compared with OMT alone in patients with stable coronary artery disease. FFR-guided PCI consisted of FFR measured preferably with intravenous adenosine via a central line, PCI only if FFR less than 0.80. Second generation drug-eluting stent was utilized, and dual antiplatelet therapy for at least 1 year. This slide shows a FAME2 trial flow chart. Stable coronary artery disease patient in whom at least one stenosis was functionally significant, that means FFR less than 0.80, were randomly assigned to FFR-guided PCI plus best available medical therapy, PCI group, or the best available medical therapy only, medical therapy group. Patient in whom all stenosis had an FFR of more than 0.80 were entered into a registry and received the best available medical therapy. The primary endpoint was a composite of DES-MI or urgent revascularization. Recruitment was halted prematurely after enrollment of 1,220 patients. A significant between group difference in the percentage of patients who had a primary endpoint event. 4.2% in the PCI group and 12.8% in the medical therapy group. Hazard ratio with PCI 0.32, 95% confidence interval 0.19 to 0.53. P-value less than 0.001. The difference was driven by a lower rate of urgent revascularization in the PCI group than in the medical therapy group. In particular, in the PCI group, fewer urgent revascularizations were triggered by a MI or evidence of ischemia on electrocardiography. Also, 5-year follow-up showed marginal evidence of a decrease in the incidence of MI. Here, let me discuss why not shown a decrease in death or MI with revascularization. There might be two possible explanations for that. First, in this trial requiring angiographic evidence of obstructive coronary artery disease, patients with high-risk anatomical features may have been excluded. And knowledge of the anatomy may have led to revascularization in patients who were randomly assigned to a conservative strategy. Second, previous studies allowed the enrollment of patients with any level of ischemia, which resulted in a minority of patients with moderate or severe ischemia for whom an invasive strategy might have been most beneficial. In fact, Hakamovich et al. Showed that the incidence of death from cardiac cause was lower among those with at least 10% ischemia on myocardial perfusion imaging who underwent RA revascularization than among those who did not undergo revascularization. However, based on this meta-analysis consisting of 5 randomized controlled trials demonstrated that in patients with stable coronary artery disease and objectively documented myocardial ischemia, PCI with medical therapy was not associated with a reduction in death, non-fatal MI, unplanned revascularization, or angina during follow-up, compared with medical therapy alone. So, in conclusion, ischemic trial research question would be, in stable patient with at least moderate ischemia on a stress test, is there a benefit to adding cardiac catheterization and, if feasible, revascularization to OMT? So, ischemia trial research purpose to determine the effect of adding angiography and revascularization when visible to medical therapy in patients with stable coronary artery disease and moderate or severe ischemia. Thank you for your attention.
Thank you very much. That was, I think, a tremendous basis that you've set for discussing the ischemia study we have 4 minutes for this discussion, but the way we will format it is that while some questions can be asked to you, I think majority of the discussion would happen after the presentation of the ischemia study to actually put everything into perspective. But I could just ask you one question which you could clarify for the audience, and that is that what about the differences in stents which were used in COURAGE or the previous studies? They were the first generation of drug-eluting stents. In fact, COURAGE even had bare metal stents in a majority of patients. Do you believe stent type and the generation of stents, that the newer drug-eluting stents would have implications on preventing MIs or showing a superiority of PCI over medical therapy?
Thank you very much, Dr. Zek. I think compared with the first generation drug-eluting stents, Cypher or Taxus, there's significant reduction in the stent thrombosis and the second or third generation drug-eluting stents. So if we use the second or more recent generation drug-eluting stent, we can shorten the duration of the dual antiplatelet therapy. So of course, we can reduce the bleeding events. On the other hand, if we do the short dual antiplatelet therapy, on the other hand, we can reduce the thrombotic events also in this patient. So the generation of the drug-eluting stent is a very important point in discussing the optimal duration of the DAPT and also reducing the cardiovascular events, especially in the ischemia trial, like ischemia trial patient. Thank you very much for the great question.
Thank you. Professor Nakagawa, yourself, any comments,
Oh, Dr. Tsujita, how do you think about the impact of using imaging device? For my impression, not only the generation of this, but the use or not use of imaging device has some impact on the clinical result. Especially in Japan, we routinely use the imaging device. How do you think this point?
Thank you very much. Compared with the Western country or other countries, the PCI results, the post-PCI event was significantly lower in the Japanese registry data. For example, JPCI registry. So I think the most important reason for this lower event rate in Japanese PCI patients is image-guided PCI optimization. So in discussing the optimal PCI procedures and optimal dual antiplatelet therapy duration, image-guided PCI optimization is a mandatory procedure in the index PCI procedure. So if possible, I want to plan the clinical trial using IVUS or OCT-guided PCI clinical trial.
Right. Okay, thank you very much. We would move on and we go on to the next talk because we'll have discussions at the end. The next talk is by Dr. Anwar Santoso. He's from Harapan Kita Heart Center in Indonesia, and he's going to talk about the ischemia trial. And to summarize, the ischemia trials with its implications on our clinical practice. Over to you, Dr. Santoso.
Do you hear me?
Very well. Hear you very well.
Okay, can you see my slide here?
Please start your slideshow.
Yes, it is already seen my slides.
Yes.
Okay. So, very good evening, everybody. So, thank you very much, Dr. Nakagawa and Dr. Ashok Seth, I think, for chairing this very important session. And actually, I am delighted and honored, I think, to be chaired by those very well-known speakers of the Asia Pacific. So, what I'm going to share with you this evening is regarding the ischemia trial in terms of the summary and what is the clinical implication ahead. So this is my disclosures, and as presented by Dr. Tsujita, that the research question of the ischemia question is, in stable patient with at least moderate ischemia on a stress test, is there any benefit to adding cardiac catheterization and, if feasible, revascularization to optimal medical therapy? So I think until now, we are having what is called the clinical equipoise. It means that we have the clinical uncertainty in management of patients with stable coronary disease, whether we should choose, the optimal medical treatment or we choose, the intervention. So I think to answers very robustly, I think this important ischemia research question, I think we have to do the clinical trial. So the choice is whether we should choose the explanatory trial or pragmatic trial. I think there is a substantial differences between explanatory trial and pragmatic trial. If we are talking about the mechanisms of the disease, and then it is still in the phase 2 or early phase 3 to answer, the ideal condition of a new treatment, I think we should choose, the explanatory trial. Usually, I think the clinical outcome is related to the surrogate endpoint or biomarkers endpoint. But I think in terms of addressing, I think, robustly the ischemia question, I think we have to choose the pragmatic trial. We should meet, the requirement of what is the pragmatic trial is actually. So ahead, I want to do a little bit analysis of ischemia trial in terms of the question, important question, the research question, whether this question is actually important question or foreground question to be answered by ischemia trial. And then we talk about the design. The design should be very pragmatic, but still on randomized clinical trial. And then the still fidelity in terms of the follow-up of the patient really representing the real world. The sample size is adequate in terms of meeting, the power. At least the power should be more than 80% of the population will be tested. And the endpoint, it is very important, the endpoint should be the hard clinical endpoint, not really playing the surrogate endpoint, but really the hard clinical endpoint in terms of address the question. And the conclusion should be supported by data, and the application of this valid clinical trial, I think, can influence the clinical practice and even can influence, the clinical practice guideline. Look at this slide. This is the eligibility criteria actually of the ischemia trial. The ages of the patient should be more than 21 years of age and with the moderate and severe ischemia. I just to emphasize that the patient should be having moderate or severe ischemia. Talking about the clinical uncertainty in the previous clinical trial presented by Dr. Tsujita, there is a conflicting data. Most of the clinical trial previously, prior to the ischemia, usually, I think, recruiting only patients with the low and moderate ischemic risk, not even, the moderate to ischemia, because I think the randomization, I think, is done, and then after coronary angiography was conducted. So the moderate and severe ischemia in this patient should be detected objectively by doing the nuclears by 10% of the ischemic burden presented by nuclears. And then the echo. The stress echo should be more than 3 segments, and then stress imaging like MRI, I think the perfusion should be more than 12%, and the wall motion should be more than 3 segments of the left ventricle wall. And if we are doing, the exercise stress test, I think should be less than 7 minutes with angina. The other one, I think the patient should go to the eligibility criteria of CT angiography, where the inclusion criteria, I think, should exclude, the 50% of the left main disease. because the level of disease is very important. It's very, very high risk. And then the patient, based on the guidelines, should proceed to the intervention study. An important point, I think, if we are thinking about, the clinical practice ahead, that the major exclusion criteria, I think, should be seen. It is heart failure should be excluded, unacceptable angina despite medical treatment, and ejection fraction less than 35%, ACS within 2 months. All the exclusion criteria subject, I think, has to go to the intervention study, intervention procedure. This is the study design, I think, after a stable patient, and then the patient should go to the blinded coronary CTA, and then the core lab anatomy would assess, whether this patient, I think, is eligible to the randomized study. And then the patient go to the invasive strategy, having a optimal medical treatment and the cath lab, and then conservative strategy only having optimal medical treatment alone. This is the endpoint. Once again, the endpoint is very important because it is really representing, the problem in the medical practice. It is called, the heart clinical endpoint. It is time to cardiovascular death represented by Kaplan-Meier, myocardial infarction, hospitalization for unstable angina, heart failure, and resuscitated cardiac arrest. And then during the procedure, the recruitment of the patient, there was an amendment of the protocol. And I think it's allowed, by the authority, because the protocol previously, I think, only stated only primary endpoint and then secondary endpoint. But now, after being amended by all the investigator, the component of the endpoint consists of cardiovascular death, myocardial infarction, unstable angina, heart failure, and resuscitated cardiac arrest. In terms of myocardial infarction, I think the investigator focused using the universal definition of myocardial infarction, basically procedural myocardial infarction. Because in one arm, the patient, I think, should go to the intervention procedure, and then they want to look at the side effect or adverse event of the procedural myocardial infarction in the intervention arm. This is the endpoint of the unstable angina, heart failure, and the resuscitated cardiac arrest. So anyway, it is a study flow. And interestingly, about 8,000 people initially enrolled in this ISCHEMIA trial. Only about 60% of the patients, I think, are suitable for randomized, because about 30%, 34%, I think, is not suitable for randomization. Basically, the patient was the woman gender because they have no ischemia and they have no non-obstructive coronary artery disease. And interestingly, that from the enrollment phase until randomization, it took about 3 years. So I think after that, the patient, I think, should go to the randomization to invasive procedure, and then the other one to the conservative procedure. So the question is how to analyze actually the ISCHEMIA trial. We have to be sure that how pragmatic actually the randomized control trial labeled as pragmatic. There was, using the PRECISE 2 tool, there are 2 domains should be considered. The first one, the eligibility of the patient. The patient, the eligibility criteria should be actually representing the clinical uncertainty until now, which is the patient with stable angina. And the second one, how I think the patient will be recruited. The patient recruited using the everyday medical practice in a hospital, basically in the tertiary hospital, either using the stress imaging or using the CTA as a common procedure, I think, to diagnose stable angina pectoris. And the setting in the hospital, basically in the hospital with the procedure without our very less procedurals events. And the other one is flexibility in terms of delivery. I think the patient should be delivered, the best practice of medical treatment right now. And the adherence, the patient, the result of the study should show, the adherence rate more than 85%. And the follow-up, the patient should be followed up until the end of the study. And the primary outcome really representing, I mean, the hard clinical endpoint. So this is the tool, precise criteria, how pragmatic is ischemia trial. So I think using this very simple circle, I think the wider the circle, I think the more suitable the study, I think, to the pragmatic trial. I think the closer the circle into the center of the circle, I think it is related to the explanatory clinical trial. So using this criteria, I believe that actually the ischemia trial is really representing the pragmatic trial, meaning that can address, can answer, I think, the uncertainty in the clinical practice nowadays. So we could see in this slide, in the right panel, that actually, you know, the circle of the ischemia trial, I think, is approaching the whole circle of the PRECISE 2 checklist. So this is the baseline characteristic of the ischemia trial in terms of, you know, between the arm, in terms of the ages, the gender, the diabetes, and the risk factor are the same. It means that actually the randomization was working very well. And then regarding the ischemia, using the qualifying stress, I mean the imaging stress, that actually all the patients having about 80, almost 90%, I think, having moderate to severe ischemia. Only 12%, I think, they are having the mild ischemia risk. Using the baseline coronary artery anatomy by CCT, we could see actually all the patients have, you know, comparable between the invasive procedure arm and the conservative arm, that they have coronary artery disease, except there are no or very limited, I mean, the left-main disease. So how about the risk factor management? This slide, very interesting, comparing between the last visit and the baseline, all the patients in the groups, the invasive arm and then the conservative, having the best treatment of the modern guideline. Like 95% the patient having statin, even 60% having high intensity statin, and RAS blocker about 70%. And interestingly, that the LDL target, I think, was achieved using that that guideline, less than 70% achieving more than 60%, and the systolic blood pressure less than 140, and the aspirin about 90, more than 90%, they are having aspirin, and the smoking program was quoted about 90%. So once again, looking at the risk factor management, the patient in both arms, I think, are treated very well according to the recent clinical practice guideline. And then this is the medication use over time. We could see actually the APT, I think, was utilized in this patient, basically in the group with the intervention, and the anti-anginal medication, I think, was only used, beta blocker and calcium channel blockers. What kind of risk vascularization, I think, was utilized in this ischemia trial? I think about 74%, they proceeded to the PCI, and about 26% they are having CABG procedure. So this is Kaplan-Meier's curve showing actually in terms of the primary composite outcome, there is no difference between the invasive strategy and conservative strategy. Only in the early 6 months, there is a little bit increase of the, basically myocardial infarction. It is driven by the myocardial infarction because I think it is sensitive to myocardial infarction definition in terms of the procedure, because they are very sensitive to this definition. This is which is called, I mean, the Fortis plot. Fortis plot just want to test it. I mean, is there any covariate that take place in the association between the medical treatment and invasive strategy to the clinical outcome? Actually, by doing the heterogeneity test, there is no differences between the treatment to the clinical outcome, meaning that actually in the ischemia trial, the conservative management and the intervention management, I think, can take a place without influenced by the covariate. So the design of the study, I think, is very robust because I think it is, pursue the specified Bayesian analysis, meaning that they want to estimate the probability of difference between the two arms. And the population studied or recruited, about 87% of the population having moderate or severe ischemia, which is not addressed by the previous clinical trial. And then the sample size, I think, is very powerful because more than 80%, with the difference 18.5% relative risk reduction in terms of the primary endpoint. And then the endpoint is we know that actually it is representing the hard clinical endpoint. The conclusion actually I think addressed by the current issue and then supported by data. So I think the applicability of the ischemia study in the long term, I think would potentially change our clinical practice based on the clinical practice guideline, I think, ahead. So how about the patient point of view? I just want to quote, the American College and American Heart Center.
You are at 15 minutes, so would you please sum up rapidly?
Yes. So adherence to recommendation can be enhanced by shared decision making between clinician and patient, with patient engagement in selecting intervention based on individual value and preferences. So this is the conclusion. The ischemia is the largest pragmatic study of intervention and control strategy for stable angina. And overall, we could see actually that the initial INVS strategy compared to non-conservative strategy did not demonstrate a reduced risk over a median of 3.3 years. And the study is achieving good pragmatic study and presenting the real world, and we should complete reverse in ischemic territory ahead. And we should achieve optimal medical treatment based on the guideline in order to have better long-term clinical outcome. Thank you very much, Dr. Ashok, Seth, and Dr. Kanagawa. Thank you very much.
Thank you.
I'll hand it over to you.
Yes.
And now we have some time for a discussion about the interpretation of ischemia study. First of all, I want to know the impact of this ischemic trial on your daily clinical practice in your own country. Dr. Seth, in India, how about do you feel any impact or change, clinical change with this study?
So two important things. Let me just, I'm on unmute. So two important things, and I want this for all the listeners as well. You see, on one hand, it's guideline-directed medical therapy. You must understand that these patients were supervised weekly. In Asia Pacific, they were even provided with the medication. Majority of them were on 4-drug regimen, and it was targeted to achieve the targets. That's the sort of medical therapy which is not usually followed. So it was artificially in an artificial scenario, a very strict guided medical therapy. On the other hand, the PCI, as you yourself said, was not necessarily an optimized PCI. It was routine run-of-the-mill PCI being done. So how do I interpret it? I interpret it in multiple ways. Firstly, of course, I think everybody should interpret it by saying, at least we now know that if there is a high-grade stenosis and if the patient is symptomatic, it's not as if heavens are going to fall and he's going to actually have a mortality in the next few days. He can be treated medically and should be given good advice. However, we must also remember that 70% of the patients do not fit into this. We have ACS patients who are not in this, left main, very symptomatic patients. These are the patients who've had ACS in the previous 2 months. These patients were excluded. So that includes 70% of the patients. It's only applicable to 30% of the patients who come to us with stable coronary artery disease. Finally, it's important to realize that procedural MIs were increased with invasive therapy, but as time went on, spontaneous MIs were reduced with invasive therapy. And you see the curves crossing at 2 years. What does that mean? That means that if you can do a safe PCI in those who perhaps live far away, remember the fact that 28% had an admission and 23% had a PCI at follow-up. There's going to be a huge amount of crossovers. So if you can do a safe PCI on an elective basis in the initial stages for those who live far away and may not have any help available to them, it is worth it, provided it's image guided,
because that would improve even outcomes further. So the only thing it's offered to me is the ease of the fact that I don't have to rush into revascularized patient. I can give them the option of guideline-directed medical therapy, but that has to be very supervised and very followed up in larger cities rather than in smaller cities.
Thank you. So, Dr. Alan Fong, I want to know the impact of this ischemia trial in your country, Malaysia. Do you have any?
Thank you very much, Professor. I think in Malaysia, we have a balanced multi-ethnic population that is distributed amongst urban and rural areas. We have approximately 100 cath labs for a population of about 35 million people. And I think in this case, there is a lot of room for medical therapy. And like what Ashok has mentioned, it is also very important that if they are given guideline mandated medical therapy for stable coronary artery disease, that they should actually take them. And the compliance of this treatment is very important. In Malaysia, in the public health sector, many patients are given treatment which is heavily subsidized by the government. So the patients pay little or very or nothing for their pharmacotherapy. That also has a different kind of implication to ensure somebody has to make sure that because they are not paying for the medication themselves, that they should actually be very strict in taking the pills. If they do that, then the situation is very good because it is comparable to a revascularization strategy as demonstrated by the ischemia study. And just to complete the discussion, similar to India, most of our patients, many of our patients actually do not fit in the entry criteria, the eligibility criteria. And because like in my center, we look after a very large area, a public hospital that's looking after 124,000 square kilometers. And many of these patients actually present with us with early or with ACS or very severe angina. And these are the ones excluded from the ischemia study. So I think we should take this into context. But again, it's very important data. And coming in from Professor Ken earlier on, a development in the evidence pool for the management of stable coronary artery disease.
Thank you. So, Dr. Santoso, how about in Indonesia about this point of clinical?
Yeah. Okay, thank you, Professor Nakagawa. I think in a country, I think we have about 250 cath lab across the country for about 250 million people in Indonesia. I think the big country and big population I think we have. So I think we have the opportunity in terms of using the medical treatment, I think, based on the situation in our country. So I think there is still the avenue, I think, to treat the patient basically with the treatment with the stable angina pectoris. I think not everyone can go to the cath lab. I think they can be treated with the medical treatment strategy. And fortunately, in our country, we are having only already 5 years, I think, universal coverage. All the medication, all the procedure, I think, are supported and covered by the system in our country, even though the premium is not as high as in Malaysia or in a developed country. But I think it is more than enough. I think basically, I think to push the patient into the medical management. But I agree that looking at the ischemia trial, we have to be interpreted this study, I think, very cautiously, because there were limitations of the study. Basically, that this study, I think, is not that easy to be generalized. I think to the female genders, because very few female gender, I think, are included in this clinical trial. And the other one, and don't forget that the exclusion criteria of this ischemia trial all the patients with the heart failure due to the ischemic heart disease, the patient with the ACS, the patient with ejection fraction less than 35% should go to the interventions procedure, I think, to look for, the ischemia. And the other one, I think, this study, I think, can wear to the medical professional that in doing, in planning do the procedure, the invasive procedure, they have to look for the objective evidence in terms of the ischemia, whether using the treadmill or exercise stress or using the coronary CT angiography. So I think the way ahead, I think the medical professional in the country should follow the clinical guideline. I think we already developed by our society. Okay.
There was a question in the audience, and then we will go to the next talk. There was a question from the audience that is assessment of ischemia always necessary in deciding medical therapy versus PCI in the light of ischemia study? So Dr. Santoso.
Sorry, what is the question?
The question was this is from the audience, that is assessment of ischemia always necessary to guide the decision-making between choice of medical therapy versus intervention in patients with stable coronary artery disease?
Yes, I think so. I think it is imperative, I think, to find, the objective myocardial ischemia. It is very important. Except for the patient having acute coronary syndrome, I think everything is already on the table with the say, for example, the myocardial infarction or unstable angina. I think the evidence is there on the table. But looking at the dealing with the stable angina, I think the medical professional doctor should find, the objective myocardial ischemia. It is imperative to do so.
So I will then at the end bring up the point that even when there was moderate to severe ischemia demonstrated, medical therapy did as good as PCI. So what helps you? It's symptoms which got improved. Not the extent of ischemia was not the indicator for the choice of therapy. So my answer to you is, I would think that the symptomatic status of the patient would guide therapy of PCI versus medical therapy more than just demonstration of ischemia.
So I think there is still the space. I think the doctor, I think, can make some discussion with the patient. So I think based on the evidence-based medicine, the patient value and the patient preference is very important to be considered. This is, I think, the good medical practice. If the patient, I think, choose, the intervention study, okay, let go. The patient go to the cath lab. But I think the medical treatment is very important to do first. Once again, the discussion with the patient is very important in terms of patient preference and patient value.
I think so. That's great. I think it makes a big responsibility for us as clinical cardiologists, as an interventional cardiologist, to find the right approach for the right patient. Ischemia clearly demonstrates that medical therapy has moved a long way and is a viable option for every patient who's got stable coronary artery disease.
Yeah.
With that, we should move on. And I think that we move on to Dr. Alan Fong from Malaysia to discuss about the DOACs and its use in ACS in stable coronary artery disease, an update on the data. That's very important because a lot of that data has actually come from the Asia Pacific region. So over to Dr. Alan Fong.
Thank you very much, Ashok. So today, and just to go on beyond the intervention and revascularization to a pharmacotherapy approach in terms of antithrombotic type measurements and treatments. These are my disclaimers. So for the background, we know that DOACs, or this has a net clinical benefit compared to VKAs, predominantly warfarin, in the management of patients with non-valvular atrial fibrillation. Now, patients with acute coronary syndrome and stable coronary artery disease are typically prescribed antiplatelet therapy, especially so when undergoing PCI. However, there is a risk of bleeding-related complications, and this remains a concern, particularly if the patient has concurrent atrial fibrillation requiring anticoagulation. And therefore, there have been recent trials that continue to provide evidence which are subsequently incorporated into guidelines. This was the first large paper which we consider published in Circulation for the cardiovascular interventions and the management of antiplatelet anticoagulant therapy in patients with atrial fibrillation in the setting of ACS or PCI. And this concluded that in triple therapy with oral anticoagulation, aspirin and clopidogrel is recommended for patients with atrial fibrillation with ACS and or PCI, but the evidence mainly stems from observational series, mainly from single centers. So for this reason, at that time in 2014, the European and US guidelines assigned a C level of evidence to this recommendation, and they emphasized the need for balancing the thrombotic and the bleeding risk at the individual level. So also in 2014, this was the guidelines. I think it is important to have a look at this at a closer basis, published in the European Heart Journal. And essentially, without looking at it in too much complicated areas, that it actually comes down to 4 steps. So the first step is to assess the stroke risk, and hereby using the CHATS-VASc risk stratification score. Second is to determine the bleeding risk, and for example, here using the Hasbled score. The third step is looking whether the patient has stable disease or acute coronary syndrome. And finally, designing antithrombotic therapy that will balance the risk of ischemic complications versus the bleeding risk. So this is in 2014. I'll start with the Hasbled score here, and this was published in 2010 and validated for warfarin, but not yet for the new anticoagulants. And I think it is important to pick up the higher risk patients of Hasbled score 3, 4, or 5, which has an incremental type bleed risk for 100 patient years of 3.7, 8.7, or 12.5. And as you can see, this is substantially higher, going from 0 to 2. So anyone who has a Hasbled score of 3 or above presents an increased bleed risk in patients with warfarin anticoagulation. For major bleeding, if you recall, it's a matter of intracranial bleeding, hospitalization, a hemoglobin decrease of 2 grams, or requiring blood transfusion. So by 2018, because of the interest in this arena, in CardioPulse published in the management of antithrombotic therapy in AF, patients presenting with ACS and or undergoing PCI. This was a joint consensus statement with the EHRA, the EAPCI, the ACCA, HRS, and including our own Asia Pacific Heart Rhythm Society, Latin America, and that of Southern Africa. And this is probably the most important slide to date, and really it looks at these patients with atrial fibrillation presenting with elective PCI or ACS undergoing PCI. So if you are concerned about the thrombotic risk, and then you would look for 1 month of triple therapy, and then triple therapy for up to 6 months, a dual therapy using oral anticoagulation or VKA with clopidogrel for 12 months, and then OAC alone after 12 months. If the bleeding risk remains elevated, then the triple therapy is only limited to a 1 month position, and 12 months on dual therapy with clopidogrel, and finally, if it's a very high bleeding risk, only on a OAC or NOAC with clopidogrel for 1 year, and subsequently on OAC alone. In this statement, it's also important to note that the OAC is either a VKA with a TTR of more than 70% or a NOAC. So in many of these cases, the patients actually drop the antiplatelet therapy beyond the 12-month period, giving the emphasis of preventing thromboembolic events due to atrial fibrillation. So I'll just do a quick run through of a few of these papers that present with these DOAC data. And I will limit mainly for rivaroxaban, dabigatran, apixaban, because in Malaysia, we do not yet have edoxaban in our clinical setting. And there was some talk about dabigatran, and I think in the issue of MI, and you can see in the post-hoc analysis of the pivotal phase 3 RELY analysis, patients on the recommended dabigatran dose showed a similar risk of MI compared to a patient on warfarin. In this case, there was no real difference in terms of looking at the efficacy endpoint for MI favoring dabigatran or warfarin. Also importantly, if they had a previous or prior diagnosis of coronary artery disease or myocardial infarction, in terms of thromboembolic risk, MI, cardiac death or cardiac events, major bleeding, really there was no real difference in terms of patients whether they had a prior CAD or not. And there are numerous real-world analyses consistently demonstrate that dabigatran has similar or better cardiac safety versus warfarin. Unfortunately, there have not been any head-to-head trials between the DOACs. Across the patient population in the pivotal studies of RELY, ROCKET AF for rivaroxaban, Aristotle for apixaban, and ENGAGE for edoxaban, the MI rates in the warfarin arms in this trial, despite being a bit varying, actually similar rates of MI with standard and lower dose NOACs versus warfarin have been shown. In the ACS population, this was the Atlas TIMI 51 study involving rivaroxaban in patients with recent acute coronary syndrome, and Malaysia is a clinical trials country for this, and our hospital a clinical trial site. And in this study, it was a double-blind, randomized, placebo-controlled trial to evaluate the safety and efficacy of rivaroxaban in these patients with clear-cut ACS. So in this study, we looked at 2.5 BD or 5 milligram BD of rivaroxaban versus standard treatment. And at the 2-year Kaplan-Meier estimate showed a significant reduction in the estimated cumulative risk using both combined rivaroxaban doses versus the standard antiplatelet therapy versus placebo. This looked quite impressive. However, there was an increase in non-CABG TIMI major bleeding in this 2-year Kaplan-Meier estimate. And as you remember, this did not show any difference significantly in terms of fatal bleeding, intracranial hemorrhage, or fatal intracerebral hemorrhage. So looking further in patients with stable cardiovascular disease, a dual target pathway approach was looking at the CAD or PAD patients who were investigated in the COMPASS study. And here, this study was to determine the efficacy and safety of rivaroxaban, the vascular dose of rivaroxaban plus aspirin, or aspirin alone to reduce the risk of MI, stroke, or cardiovascular death. And this was a long average follow-up 2-year study at the early termination. So in this study, if you look at the different doses, the different arms, the gray being the aspirin, that for rivaroxaban 5 BD in the light blue, and rivaroxaban lower dose 2.5 milligrams BD plus aspirin, you could see that the cumulative incidence rate was lowest on the rivaroxaban 2.5 versus aspirin 100 milligrams. The bleeding event rates were low with rivaroxaban 2.5 milligrams BD versus plus aspirin versus aspirin alone, and this was reassuringly not seen any differences in the fatal intracranial bleeding. So I think in the whole, this dosage of using aspirin 100 milligrams and rivaroxaban 2.5 milligrams seemed to confer a net clinical benefit in this group of patients. And because of this, this was incorporated actually in our Malaysian guidelines for stable coronary artery disease, published in the last year, the 2018 version, where we recommended the reduction in cardiovascular events in patients who require rivaroxaban 2.5 milligrams and aspirin 100 milligrams daily in high-risk stable CAD patients. The recent publication and presentation of apixaban in ACS or PCI was seen in the Augusta study. And this was a very important study, in my opinion, looking at a primary outcome in patients of such, looking at major bleeding or clinically relevant bleeding. And in the primary outcome of cumulative event rate If you use placebo alone compared to aspirin, the placebo arm showed a significant reduction in major CRNM bleeding in this group of patients. Apixaban and placebo in the dotted light blue arm, the line showed a substantially reduction in cumulative event rate at 180 days since intervention. The highest level of bleeding was if you added in the BKA here with aspirin at approximately more than double the event rate, 80.7%. So in conclusion, the Augusta study showed that amongst patients with atrial fibrillation and a recent ACS or PCI receiving a CP2Y12 inhibitor and oral anticoagulation, the use of aspirin acutely for up to 30 days approximately resulted in an increased risk of severe bleeding and reduction in severe ischemic events. But after 30 days, aspirin continues to increase bleeding without significantly reduced ischemic events. So similar to what was discussed earlier by Dr. Santoso, these results also should inform patient-centric shared decision-making regarding the ideal duration of aspirin after ACS or PCI in patients receiving oral anticoagulation. So the trade-off between bleeding and ischemic events here, as you can see, the stent thrombosis of ischemic type events happen early. The bleeding risk remains accumulative and is higher with long-term potent antithrombotic therapy. And therefore, it's very, very important to consider these patients in this criteria. So in 2019, the focus update from the 2014 original document, which I showed you from HRS, showed that there was a lot more to do in terms of these patients. I think it is very important, therefore, to have a balanced risk. And I conclude, therefore, in DOACs and ASS and PCI, vascular thrombotic events versus bleeding risk. And I discuss mainly only on dabigatran, rivaroxaban, apixaban here, whereby the DOACs are preferred over BKA for anticoagulation in non-valvular AF with a broader patient profile compared to non-clinical trials. So I guess more real-world evidence, particularly here from the Asia-Pacific region, is very important to guide how we manage these patients. And with an increasing elderly and aging population in Asia, this will become a greater clinical dilemma for us in practice. Therefore, individualized therapies or precision medicine, maybe point of care for DOACs, telemedicine, and shared decision-making will directly influence clinical outcomes, just as how an interventional cardiologist who is experienced will provide a better clinical outcome than someone who is less. So here are a few examples of point of care genotyping. Here, the Spartan system on the SIP2C19 with a 1-hour result, and the Clot Pro system is similar to a point of care for anticoagulants of the DOACs. So you can see the direct effect of the DOACs on the clotting system. So with that, I thank you very much.
Thank you. Nice presentation. Are there any specific questions or comments to his presentation?
Oh, yes, yes. I think, Dr. Fong, that was a great presentation. Now, let's put this into perspective for the audience. That was good about the COMPASS study and the 2.5 milligram twice a day. Where would you actually state, now you have antiplatelet regimes, think that you've got a patient with acute MI who's, of course, at a higher risk of events over a long-term period, and now a year has passed by, and he's had ACS and he had aspirin and ticagrelor for 1 year. Now, after that, and he's got peripheral vascular disease, he's got other issues, that he's a higher risk for cardiovascular events for a long period of time. He's a diabetic, he's had previous MIs in the past. Now you have the option of aspirin plus ticagrelor at 60 milligrams. That's been recommended for long-term protection based on Pegasus. And now you have the option of rivaroxaban 2.5 milligram twice a day in addition to aspirin. Where would you start using the 2.5 milligram twice a day of rivaroxaban?
So that's a really difficult question. Actually, there's still a lot of situations, scenarios where we have to balance of risk and thrombotic events. I think, for me, I mean, if to look for a clinician, I'll be very happy to come to see you in Fortis to get your personal opinion. Because in reality, every clinical scenario is different. And in Malaysia, where my clinical practice is, the risk of bleeding is quite frightening, particularly if the patient goes back to a rural setting. If they have any form of hemorrhage, it could be a really life-threatening situation. So that would be one of the more important areas for me to consider. In the context of a stable patient with a previous history of a myocardial infarction, I think the compass type regimen would be more suitable for them, given a low dose rivaroxaban with aspirin. And I think that has some beneficial effect in certain subgroups, particularly those who have poor left ventricular function and with higher risk of developing thromboembolic events. So I think these would be my kind of patients, and that would be the regime that I would prefer over the Pegasus type regime.
So can I just ask you that in your practice, how often do you use for stable or unstable coronary artery disease rivaroxaban 2.5? And I'm not talking about atrial fibrillation being present, because obviously those doses are not for AF. The doses for AF, by the way, and as was used in Atlas, was also high doses were used. But which are the real patients that you end up using it? And that's, I think, for all of us to understand from you.
No, I think like from my clinical practice, I would pick the aspirin versus rivaroxaban low dose, the compass result. If I were concerned about prevailing thrombotic event risk, like for example, this is not atrial fibrillation, but those patients with some mitral regurgitation, with poor left ventricular function, and these are the ones I think should be protected more in terms of dual inhibition, primarily because at the moment we are very lucky in Malaysia because we just had this dose approved by our regulatory authorities. Right. So we haven't actually got it out yet. So I think when it is out, if I have a relative that fits within that criteria, these will be the ones I would use.
Okay. Over to the panel. I'm sure questions, if there are any questions from the panel. We still are sticking to time, by the way. We would actually have, we would have enough point of discussion for the last talk as well. Okay. Dr. Nakagawa, any other comments on this issue? So I think if there are none, we should move over to Dr. Nakagawa's talk. And I think that's a very important talk. That is to do with short DAPT. Again, the proceeding from Dr. Fong's talk to the balance between bleeding and ischemia. And some of the seminal studies, as you know, of short DAP2, smart choice, were actually from the Asia-Pacific region. And I think it's great that we actually have Dr. Nakagawa to talk to us about decreasing the DAPT and balancing out the ischemic risks.
Okay.
Over to you.
Can you hear me also? Can you see my slide? Okay.
Absolutely, we can.
Okay. So it's my great honor to make a presentation in this APSC JCS web meeting in 2020. And this is my disclosure. As a background, in bare metal central era, mandatory 1 month DAPT had been the standard of care. After introduction of DS, DAPT duration was prolonged without firm scientific evidence. New generation DES has substantially reduced sensor thrombosis rate. Prolonged DAPT is inevitably associated with increase in bleeding. Therefore, short DAPT duration after DS might be an attractive option if not associated with increase in ischemic events disproportionate to the reduction in bleeding events. So, as Dr. Seth mentioned, we performed a stop DAPT trial, 1 month DAPT after coronary drug resistance implantation in Japanese patient. And the stop DAPT trial is a prospective multi-center open-label randomized trial comparing 1 month versus 12 month DAPT after cobalt chrome ES giant stent implantation with limited exclusion criteria. At 1 month DAPT group, this is the experimental arm were to stop aspirin at 1 month and to receive clopidogrel monotherapy up to 5 years. While patient in control arm, this is the standard therapy, both aspirin and clopidogrel were continued up to 1 year. Then clopidogrel was stopped, then aspirin was continued to use up to 5 years. And this result is a primary analysis for non-inferiority of this experimental arm and for non-inferiority analysis. This slide shows the endpoints of this study. Primary endpoint, we call this net clinical benefit, both composite of ischemic event and the bleeding events. A composite of cardiovascular death, MI, definite sense thrombosis, stroke, or major or minor bleeding. And the major secondary endpoint was both individual endpoint of ischemia and the bleeding. And this is this slide shows primary endpoint result. 1 year cumulative incidence of primary endpoint was 3.7% in 12 months DAPT group and 2.4% in 1 month DAPT group. So 1 month DAPT was not only non-inferiority, but also superiority was examined. And this slide shows major secondary ischemic endpoint, and there is no significant difference between two groups, almost even, but numerically incidence of ischemic event was lower in 1 month DAPT group. And this slide shows major secondary bleeding endpoint, and 1.5% in 12 months DAPT group, and only 0.4% in 1 month DAPT group. So the rate of bleeding was remarkably low in 1 month DAPT group. So also I have to mention that this top-down trial in both groups, imaging device was used in as high as 99% of patients. So I have to emphasize that this study was performed under the guidance of imaging device, mainly intravascular ultrasound. And this slide shows the conclusion of top-down trial. 1 month DAPT followed by clopidogrel monotherapy provided a net clinical benefit for ischemic and bleeding events over 12 months DAPT with aspirin and clopidogrel after cobalt chrome everolimus eluting stent implantation. The benefit was driven by significant reduction in bleeding events without increase in ischemic events. So, as you know, last year, high bleeding risk definition by ARC was published in both Circulation and European Heart Journal. And as you know, this is a slide illustrate of the factors associated with an increased bleeding risk after PCI in this ARC high bleeding risk definition. And we performed a post hoc subgroup analysis of the stop-duct trial based on the definition of ARC high bleeding risk criteria. The risk of 1 month the effect of 1 month DAPT for the primary endpoint were consistent in both high bleeding risk group, also non-high bleeding risk group. But these results, however, the benefit on 1 month DAPT was numerically greater, much greater in high bleeding risk group, and very small benefit in non-high bleeding risk group. So recently, in Japanese Circulation Society published, developed guideline-focused update on antithrombotic therapy in patients with coronary artery disease. Because important evidence such as Otsu trial has accumulated about the antithrombotic therapy after PCI. So this slide shows factors for assessing the thrombotic risk in Japanese patients in the update guideline. And as you can see, we assess the risk factors for the thrombotic event, also assess the risk factor for stent thrombosis. And we added the, included the stent length or the complicated degree of the procedure. Also, we identified that these ACS patients, severe CKD patients, CTO patients, diabetic patients, these factors are identified very important ischemic event risk factors. And this slide shows the Japanese version of high bleeding criteria modified from ARC high bleeding risk. As you can see, the low body weight frailty, especially body weight less than 50 kilogram, history of heart failure, anemia, peripheral vessel disease, also severe CKD, including dialysis. These factors are identified, and we propose these kind of factors are independently associated with bleeding complications, particularly in Japanese patients. So this illustrated is our proposal of Japanese version of high bleeding risk criteria. And this slide shows the antithrombotic regimen based on the Japanese version of high bleeding risk criteria. Bleeding risk should be priority in determining the use of antithrombotic drugs, and thus present guidance recommended that the antithrombotic regimen should be determined based on the Japanese version of high bleeding risk. When switching from the very short-term DAPT was recommended, and after the stop of DAPT, at the time of change to single antiplatelet therapy, we recommended the monotherapy of P2Y2 receptor inhibitor. It should be considered rather than aspirin monotherapy. This slide shows the conclusion of my presentation. There is increasing evidence of the safety of discontinuing aspirin 1 to 3 months after PCI with continuation of P2Y12 monotherapy. Whether this strategy is safe in patients at high risk of ischemic event, especially for stent thrombosis, such kind of ACS patient or very complex PCI procedure remains uncertain. This is my additional comment. Stop-Apps trial candidate mainly stable artery disease. So Stop-Apps ACS trial is currently in progress in Japan. Already enrollment has almost finished, which ACS patient under PCI randomly assigned to 1 month DAPT and 3 months DAPT. And thank you very much. It finished my presentation.
Thank you very much, Dr. Nakagawa, for an excellent presentation. The STOP-TAP2 is a very vital study and came along with Smart Choice from Korea. So we're really thankful to the Japanese investigators and the Korean investigators for these landmark studies. Clearly, what I would like and the audience would like to ask you is that you're certainly not recommending a 1-month DAPT as a standard of care, are you? Would you be? Are you say stable coronary artery disease, standard procedure performed? What is your X duration of DAPT?
Now it's changing to shorter and shorter, but
Correct.
mainly
How short?
3 months to 6 months, and
3
the
months.
1 month DPT duration is still
Well,
challenging, but
for high bleeding risk.
sorry, it's changing to shorter and shorter.
So that's very important. It's for high bleeding risk. You're not saying that 1 month is better than 6 months. What you're saying is for high bleeding risk patients who are optimized by intravascular imaging, you can actually have 1 month DAPT followed by single antiplatelet without compromising on ischemic outcomes. Correct? That's what you're saying.
Yes, it's very important point, especially if we interpret the result of Stop trial. The randomization was performed after the finish of the PCI procedure. So the result was confirmed with intravascular imaging. So even if the small dissection was observed, we didn't enroll the patient to this study. So only very high quality result patient was enrolled as this kind of prospective randomized trial. So it's very difficult to apply to all kind of patient. It's very difficult to get the perfect result to all patients.
Can I have final?
Go ahead.
Okay, Dr. Nakagawa, I think very nice presentation regarding the Stop the APT2 study. But I think looking at the number needed to treat and number needed to harms of the study, it is not quite impressive because I think the NNT is about 78 or 80, and the number needed to harm is about 90 something. So I think, do you think that this study, it is caused or affected by the phenomenon which is called the East Asian paradox, basically in the Japanese and the South Korean population? What do you think?
Oh, it's very important point, and as you mentioned, the so-called East Asian paradox, especially in Japanese patient, very easy to breathe, and the incidence of ischemic event is very low compared to the Caucasian. So I feel strongly such kind of East Asian paradox, and it's not the same, by racial difference exists. How do you, Tsujita, consider about this point?
Yeah, I agree with Dr. Nakagawa's opinion. There is some between racial difference, especially in the breeding events. So we need racial specific evidence for each country.
So I'm going to bring in one more point, and we have time for that, and that's that aspirin was discontinued and clopidogrel continued. And yet in Asia Pacific, we're uncertain about the dysfunctional, the prevalence of dysfunctional CYP2C19 allele. We believe that nearly 20-25% of our population may actually be clopidogrel resistant. So did you actually consider that in continuing clopidogrel? I know the results are good, but there's the optimization issue. Now, if I was going to actually use it in my practice, I'd be very concerned that I'd probably end up using a new P2Y12 inhibitor rather than clopidogrel if I was going to stop the DAPT at 1 month's time. More for the predictability of clopidogrel response. So Dr. Nakagawa, as well as...
as you mentioned, this Stop trial is not the study comparing which is better, clopidogrel or aspirin monotherapy. We cannot get the result with this study design. But actually, with the use of aspirin monotherapy, the increased rate of the gastrointestinal bleeding So we prefer to use the P2Y12 monotherapy. Also, in Japan, plus is often used instead of the clopidogrel. Also, in my hospital, we routinely check the phenotype.
Right. So I think that actually answers. Any other questions? We are actually on time. So Dr. Nakagawa, last words from you, please.
Okay. So I would personally appreciate to all both speakers and the audience providing such an interesting session and the discussion. So next year, after the finish of this pandemic, the welcome to Japan. Also, we hope we have a chance to have Tokyo Olympic. So this session is now closed. Thank you very much.
Thank you very much.
Thank you very much, dear friends. It was a pleasure being here and pleasure being at the Japanese Circulation Society meeting along with APSC.
Thank you.
Thank you very much. Bye.
Thank you.
Bye.